Good afternoon and welcome to our second section of the Certified Revenue Cycle Representative coaching courses that Florida HFMA is offering our members and many of members joining us from other states. So welcome. We went through sections 1 and 5 last week, and you should have reviewed the material on the HFMA website. I wanted to give you a few minutes for you to ask any questions via the chat on any of the material before we move to sections 6 through 10. 6 through 10 will go through compliance, ethics, volume to value, financial overview, and key performance indicators. I'm calling this section the mnemonic section because it is absolutely amazing how many mnemonics we currently have in healthcare, revenue cycle, and finance. Okay, no questions, so we'll move on. So we're going to talk about compliance and coding issues specific to patient revenue cycle. We'll also learn terms such as the MSDRG window, the TwoMidnight Rule, correct coding initiatives or CCI, modifiers, and the Medicare secondary payer or MSP. From the beginning of the Medicare program, certain payers have always been liable for the payment of claims. More recently, with the enactment of Medicare Part C or Medicare Advantage plan options, this principle is expanded to include work-related injuries and accidents, workers' comp, Black Lung Program services, Veteran Affairs services, patients' enrollment in a Medicare Advantage plan, federal grant programs, and public health service programs. In these cases, Medicare does not make a secondary payment. The amounts paid by the primary payer are considered payment in full. In recent years, the OIG has been reviewing these claims to ensure compliance with the MSP rules. Medicare Advantage plans have their own policies that outline any coordination of benefits. Understanding the health plan's documentation requirements is essential if the provider is considered a participating provider and has an active contractual arrangement with the plan. So some of the MSP situations that we'll work through, and anybody that's been in patient access understands these can be very complex. Anybody that works in the billing office understands the types of denials that happen if we don't get this right. So working age, the patient is age 65 or more, is employed, and the patient has group health coverage through the workplace. A group health place is a GHP is a group health insurance plan provided by an employer that has 20 or more employees. If the employer has less than 20 employees, the group health plan does not qualify as the primary payer, and Medicare is billed as primary. The patient is not required to accept the employer's insurance coverage. In that case, Medicare would be primary. The employer is prohibited from offering a supplemental policy in place of the standard group health plan benefits offered to other employees. Accidents or other liability. When the patient needs medical care as a result of an accident, the liability insurance company may be responsible for payment. Automobile accidents as well as premise accidents are included in this MSP category. Health care providers are required to obtain the billing information for the liability carrier. Liability is primary only if the accident did not occur on the patient's own property and if the patient states there is a liability. Required coding on the UB04 includes the occurrence code and the date of the accident. If no medical payment or other third-party coverage exists, occurrence code 05 and the date of the accident or injury must be provided. Disability. The patient is eligible for Medicare due to a disability, is under the age of 65, and has group health insurance coverage through a large group health plan. That is defined, that is a plan that is provided by an employer that has 100 or more employees. And certainly end-stage renal disease, or ESRD, from the time patient becomes end-stage renal, there is a 30-month coordination period. After completion of the 30-day coordination period, then Medicare will be primary, unless there is another MSP situation as well. The DRG window, are also commonly known in the industry as the 3-day rule. Basic things to keep in mind regarding the 3-day rule. Any non-diagnostic outpatient services is considered related to the admission if it uses the same ICD-9 diagnosis code as the principal diagnosis for the hospital admission. Any diagnostic services and related charges provided within the window are considered to be related. These include radiology, cardiology, clinical laboratory, EEG, pulmonary function, and audiology tests. Related charges include anesthesiology and drugs used to provide radiology or other diagnostic services. Services are considered to fall within the window if they are dated within 3 days before the date of the admission or on the date of admission. So for example, if the admission is on a Wednesday, any services provided on Sunday, Monday, and Tuesday, and before the time of admission on Wednesday, are within the billing window. Ambulance, maintenance, renal dialysis, and Part A services provided by a nursing home are not considered related. Two-midnight rule. So traditionally, the decision to admit a patient as an inpatient has always been up to the discretion of the treating physician. However, as CMS started looking at admissions that were less than 2 days, sometimes even less than 1 day, they decided to put in the 2-day midnight policy under the 2014 IPPS final rule. The policy says that the agency will consider hospital admissions spanning 2 midnights are appropriate for payment under the IPPS rule. In contrast, hospital stay of less than 2 midnights will generally be considered outpatient cases regardless of clinical severity. Procedures defined as inpatient only are exceptions to the 2-midnight rule and may be appropriately furnished on an inpatient basis regardless of the stay. So for anybody that's been working in patient access in a hospital setting, this explains the reason between patients going from an observation to an inpatient, maybe an inpatient to an observation. Sometimes that's made even after the patient leaves the determination. And really it's the physician needs to make the decision that when he is admitting the patient, that he believes the severity of that case will require the patient to stay more than 2 nights in the hospital. Other than that, most will say start with observation, and then if they require additional stay as their condition either changes, then we change it to an inpatient admission. The Medicare program only pays for medically necessary services. Therefore, providers are expected to screen outpatient services for compliance with Medicare coverage rules. If an ordered service does not meet medical necessity based on the test and diagnostic information provided, the provider is required to issue the appropriate Advanced Beneficiary Notice, or ABN. The ABN is the mechanism used by providers to explain to a Medicare beneficiary that the ordered test or services will not be covered by Medicare because the diagnostic information provided by the physician does not support the need for these services. Most providers will try to see if the physician has any additional diagnoses that may be available. However, a provider may not inform the physician of what they are. The ABN may also be used for voluntary notifications in place of the Notice of Exclusion for Medicare Benefits, or NEMB. By providing this notice in advance, the Medicare patient is given the cost of the test and the option to refuse or pay for the service. This allows the beneficiary to make an informed decision about whether or not to receive the items or services for which he or she may have to pay out of pocket. ABN requirements. As soon as a provider determines that Medicare most likely will not pay, it must advise the patient, in the provider's opinion, that he or she will be personally responsible for payment. Both the originals and copies of ABNs must meet the following conditions. Type must be easy to read, must be large enough for the elderly to read. Ink color and paper color must provide a high degree of contrast. Use of highlighting or shading of text should be avoided, and anything handwritten must be legible and readable. The ABN must be on the approved CMS form. Follow the wording provided to CMS to ensure that it's easily understood. Clearly identify the specific test or services identified as non-payable. Provide the information as to why it's not payable, not covered, deemed experimental, possibly frequency limits if only allowed to have that test once a year. And must clearly inform the patient of the amount that they are going to owe. Failure to provide a patient with an ABN and failure to appropriately code the account to indicate that the ABN was signed will result in Medicare denying those services, and the provider may not bill the patient. In order to promote the use of correct coding methods on a national basis and prevent payment errors due to improper coding, CMS developed the Correct Coding Initiative, or CCI. The purpose of the CCI is to ensure that the most comprehensive group of codes, rather than the component parts, are billed. The program consists of edits that are implemented within providers' claim processing systems. The CCI edits are incorporated within the outpatient code editor. The edits also check for mutually exclusive code pairs. The unit of service edits determine the maximum allowed number of services for each healthcare common procedure coding system, or HCPCS codes. Told you there's going to be a lot of mnemonics today. Modifiers may be used to indicate to the recipient of a claim that a service or a procedure potentially had both a professional and technical component, was performed by more than one physician, was increased or reduced, was performed more than once. Other modifiers indicate that only part of a service was performed, maybe an adjunctive procedure was performed, a bilateral procedure was performed, or unusual events occurred. Modifiers are also used to refer to service procedures performed on the same calendar day. Level 1 modifiers, they usually provide information about the performance of a procedure. They apply to CPT codes, and they consist of 2 numbers, i.e. 50. Level 2 modifiers provide details about an anatomical location or about a procedure. They apply to HCPCS codes. They are required to add specificity to the reporting of procedures on eyelids, fingers, toes, and arteries. Who knew? Okay. So the key points that I hope you came away with in this section so far was the importance of the 3-day window and ensuring that those bills are combined appropriately, the proper utilization of an ABN and why they are needed, when Medicare is a secondary payer under the MSP situations, and the correct coding initiatives. So an example of the questions that you'll see out there in the course is, order to promote the use of correct coding methods, CMS developed what? Well, the correct coding initiative. The purpose of the CCI is to ensure that the most comprehensive groups of codes, rather than the component parts, are built. Okay, ethics. When discussing and applying ethics in healthcare, one can bring up things like the patient's right to refuse treatment, medical professional standards, and our business or organizational ethics. So we'll dig deeper into ethics in healthcare and what it means to you as a revenue cycle professional. So why talk about ethics here? Our society is changing at a rapid pace. Expanding global economy, increasing workplace diversity, expansion of the information highway, instantaneous media coverage, not something we always want, and unique generational differences. As a result, defining and applying ethical business practices and principles is important to all industries. But healthcare services are important to both individuals and our society. Healthcare providers that work for them have additional ethical duties to the patients and the communities they serve, particularly due to the healthcare complexities that we deal with on a day-to-day basis. So let's talk about some of the ethic violations examples that you may potentially see at a provider. Financial misconduct. Well, that could be the failure to complete all the cash drawer reconciliation steps. This could result in incorrect payment receipts, posting and deposits, an amount owing due to the patient accounts. Overcharging. Physician enters a level 1, but the secretary decides to enter a level 3. Theft of property. Hopefully we've all thought about this, but certainly taking home office supplies to help your child with a school project is an ethic violation. Falsifying records to boost reimbursement. A coder, while reviewing the record, believes the physician forgot to document additional care and changes the clinical record to ensure additional reimbursement is needed. There is a reason why we have CDI initiatives out there, and that record should have been flagged for the physician and reviewed, and if additional information was needed, he could have appropriately updated it at that time. That is not the job of a coder. Miscoding claims. Biller decides to change a procedure or a diagnosis code on a denied claim and resubmits. That is definitely an ethics violation. For anybody that joined me last week, you know, I shared that happened to me 2 times. Not that I did it 2 times. I don't think I'd be sitting here talking to you, but I had staff members that we had to report for ethic violations in falsifying claims and miscoding claims. And then certainly privacy violations. We have HIPAA and PHI and all that good stuff for a very good reason. None of us want other individuals, other than those that have a need to know, access into our records. So checking the account of a neighbor to see why she was at the hospital is clearly a violation. A few years ago, some of you may remember when a whole bunch of nurses, I think it was out in Vail, were sanctioned for checking George Clooney. So it was a big media, to play. Okay, so most of you probably don't even know who George Clooney is, so I continue to age myself. Those of you who don't even know who George Clooney is, I do continue to age myself during these conversations. So, okay, key points of ethics and what you came away with is why it's important, especially in a healthcare setting. It has to be expected, maintained, and constantly spoken about in the healthcare arena. And it's very important for people in revenue cycle to maintain those ethical standards as well. So what do business organization ethics represent? So if we look at what we just talked about and we really think about things like standards, then clearly number 2, where in healthcare, both clinical and financial personnel must be fully aware and engaged in the laws and regulations that govern their work. So business or organizational ethics are relevant to the content of individuals within an organization. So they are the principles and standards by which organizations operate. Okay, volume to value, and really what CMS and healthcare is trying to do is move from I am, encouraged to do more tests, and I'm encouraged to do more stuff because the more I do, the more I get paid, right? And we recognize that we cannot continue to have healthcare be such a large portion of our GDP, right? And so we need to focus on value, and that's what many of these acts do. And we'll talk here about the Affordable Care Act is a lot more than what you're currently hearing about in the news today, so we're going to focus on those. We're going to talk about the broad provisions of the Affordable Care Act. CMS has proposed alternative delivery and payment models to move more to value, and then certainly standard quality measures. So the PPACA, or commonly known as the Affordable Care Act, or ACA, was passed and signed into law in 2010. One of its intents was it was designed to reform the healthcare system into a system that rewards greater value, improves the quality of care, and increases efficiency in the delivery of services. So this act includes provisions to improve the quality of care. That includes reducing hospital readmissions, reducing hospital-acquired conditions, not paying a provider if a certain condition that they have a readmission within a certain period of time for a certain admission, right? Try not to discharge them too fast. Improving quality physician reporting. It's looking to reform the healthcare delivery system and how providers get paid. It is encouraging, certainly, price transparency, which I think everybody's talking about right now, as that CMS mandate is scheduled to be as of January 2021, doesn't appear to be going anywhere, and certainly address the issue of waste, just charging, ordering, certainly fraud, and then certainly abuse. Okay, so what the Volume to Value initiative intended to do was establish regulations for the development and financing of accountable care organizations, or ACOs. Intended to develop new approaches to payment and delivery systems, and they've set a target to move more of Medicaid payments from volume-based to value-based and more alternative payment methods as well. So what is an ACO? An ACO is a delivery system of physicians, hospitals, and other healthcare providers who work collaboratively to manage and coordinate the care of a patient population. The point of this collaboration is to ensure the appropriateness of care, elimination of duplicate services, and the prevention of medical errors for a population of patients. So some examples of ACO types are MSSPs, which facilitates the coordination and cooperation among providers to improve care for Medicare fee-for-service patients and reduce unnecessary costs. A pioneer ACO is a model that was designed for healthcare organizations and providers that are already experienced in coordinating care for patients across care settings. An investment model, this was an initiative designed for organizations participating as ACO in the MSSP program. It is a model of prepaid shared savings that builds on the experience with the previous advanced payment model. And then ESRD is obviously intended to design the best care model for patients that are at end-stage renal disease. So a couple more, I should have asked somebody to count the number of mnemonics we're going to use today. So HBBP, this rewards acute care hospitals with incentive payments based on how closely best clinical practices are followed. and how well hospitals enhance patients' experience of care during hospital stays. HRRC reduces payments to hospital with excessively high rates of avoidable readmissions for patients experiencing certain conditions. This is to encourage proper treatment during the stay and post-treatment services in an appropriate care setting for follow-up care. And then PQR provided a financial incentive to physicians for reporting quality data to CMS. Those incentives were eventually eliminated, and they actually moved to reducing payments for physicians that did not satisfactorily report quality data. And there's two examples of some episode-based payment initiatives, such as bundling things for things like joint replacement. So Medicare's Pay for Performance initiative. So quality measures are tools that help us measure or quantify healthcare processes, outcomes, patients' perceptions, and organizational structure. These goals include effective, safe, efficient, patient-centered, equitable, and timely care. The institutions that were involved that included hospital associations across the country, the Joint Commission, Agency for Healthcare Research and Quality, many of the major payers, and in addition, the AFL-CIO union representation. So key points, ACA is just not about healthcare coverage. It was designed to also reform the healthcare systems. CMS continues to target and move Medicare payments based from volume-based to value-based, and quality is an integral part of all of these initiatives. Okay, so follow up on this area. What is the intended outcomes of collaborations made through an ACO delivery system? And an ACO is there to intended that patients receive quality care. So its real initiative is to ensure the appropriateness of care, the elimination of duplicate services, and the prevention of medical errors for a population of patients. So by meeting established benchmarks for quality and efficiency, participating organizations may receive a share of the savings generated by reducing duplicative services, improving productivity, minimizing paperwork, now wouldn't that be nice in healthcare, and other cost efficiencies, decreasing administrative burden. Okay, financial overview. This is where they get into the fun stuff of what our finance team does for us. So in this section, we'll include various financial reports governed by a number of regulations, gross revenue, net revenue, and calculations used for reporting, and then reserve amounts on providers' financial statements. So financial reports. First, they're governed by a number of regulations, including those defined by the Securities and Exchange Commission, or SEC. Financially Accounting Standards Board, or FASB, and then Generally Accepted Accounting Principles, or GAAP. Okay. The purpose is to present information that may be used by others to make determinations regarding the financial status of an organization. Income statement ties directly to the balance sheet and is the summary of the organization's revenue, expenses, and any excess or loss from operations. The balance sheet is a summary of the organization's wealth as of the date of the statement. It represents the sum of the organization's assets, liabilities, and accumulated excesses from operations less any accumulated losses. And then the cash flow statement is a summary of how cash was used and where it was obtained. Keep in mind that most hospitals operate on a very razor-thin margin, now even more than ever. And unfortunately is evidenced very sadly by the number of hospitals closing up their door. I am going to encourage you all to make sure we understand the differences of these financial reports as you go through your training and get ready to take your assessment. Okay. Accrual accounting methods is, I think these are pretty easy to see. Accrual recorded when it's earned. So I may have an expected revenue that's going to come in. You know, maybe I signed a contract. I'll think about technology vendors, right? You signed a contract with a new vendor that's going to provide you with, say, eligibility services, right? That revenue actually cannot be recognized until it's actually earned or when you go live. So that's a good example of accrual. Cash is when the payment is actually received. And then certainly fund is a record-keeping method to manage categories of net assets to ensure compliance with the restrictions of those funds. Okay. Gross and net new, I'm sorry, I didn't correct that. I did not build this slide. It should say gross and net revenue. I will correct that before it's published. So to determine, and this is very important in calculations in revenue cycle. So determine net revenue. Financial services must eliminate must estimate the dollar amount of contractual, discount, and other allowances that will be applied against those revenue. This allowance constitutes the difference between the amount billed and the amount that the payer or patient are both as committed to pay based on an agreement with the provider. Although you will see metrics that use gross revenue, most providers focus on KPIs based on net revenue as more controllable and collectible. There is a great example in the e-learning course that will walk you through a calculation of gross versus net revenue in financial reporting. So spend time and do that. So for example, what it's going to do is it's going to start at gross revenue for the month. It's going to tell you the adjustments booked at billing. And most providers should have proration rules to bring to net at billing based on expected contracted rates. It's going to then less charity care, then less provision for bad debt. And so making sure, again, that bad debt is defined as self-pay patients that chose not to pay their bill, and it is specific to bad debt. I have had hospital providers try to argue that insurance receivables not collected after a certain age should be put into bad debt, and I would argue to you that that is not accurate. So, to estimate net receivable, we talked about already what needs to go in there, so we've done that. Reserves for bad debt are estimated by considering the health plan groups and the age of the receivables. So, for example, self-pay accounts may be fully reserved at 100%, 120 days from the first bill. So the importance of calculating reserves is to really represent the older the AR, the less chance that you're going to collect that, both from a patient and from insurances. And so you need to start taking reserves. If it's insurance money, it's just going to be insurance write-offs. If it's patient liability, it's going to be bad debt. But you start to fully reserve, and any money that may be received on those amounts are then unreserved. So not a bad thing. So key points that we want to make sure is, again, determining the difference between gross and net and how to calculate to go from gross to net. And then the importance of reserves and how they are reported on the provider's financial statements as either contractual allowances, insurance write-offs, bad debts, and charity care. Okay. So which option is not a reserve amount on a provider's financial statement? So certainly contractual allowance accounts are. Bad debts are going to be on the financial statement. Charity care will be on that. A contra account is actually a contractual third-party estimate, which is posted to the accounts at the time of billing, which increases the accuracy of receivables and minimizes the need to estimate contractual reserves. I will be honest with you, this was a new terminology to me. It was something I never dealt with when we did our financial statements back in university. So I was actually, I don't really know what it is, to be honest with you. But you know, it's not an amount on the provider's financial statement, which is the most important thing. Okay. Key performance indicators, and we're almost done. Hopefully we'll have time for questions from any of the materials today, anything that was put on the chat. And then we're going to give Anthony time to talk at the end about some upcoming exciting HFMA events with the Florida chapter. So KPIs and why they're very important to you. You know, they are benchmarking in accounts receivable, whether it is against your peers or whether it's against just yourself, right? This is my baseline. Where do I want to go based on what the industry average is? You know, there are various techniques used to measure AR. And so we try to be consistent, but I assure you that there are people that don't necessarily follow the standard calculation and formula for all of those. I mean, HFMA spent a significant amount of time developing, creating, and validating the MAP keys, which shows the standard KPIs used in the industry. If you have not been out to the HFMA website, I highly encourage you to go out and review those to understand the various KPIs that the industry should be following and how those should be calculated. There was a significant amount of work done by a lot of committees and volunteers that defined those MAP keys. I was included in one of those committees, and I guarantee you it was a lot of robust conversation about the calculations. We already talked about, a few providers that report age insurance balances of bad debt, right? And that necessarily is not best practice and an indication of why sometimes AR days are not necessarily appropriately, comparing it to your industry, other people, really focus on yourself. So KPIs set standards for accounts receivable, and it provides a method of measuring the collection and control of accounts receivable. Benchmarking is used to compare key performance indicators in an organization to an agreed upon average of expected standards within the same industry. There are some key benchmarks that should be used to analyze AR within a provider organization listed below. And those are the generally, but not all, the KPIs on the slide. The exact benchmarks will vary depending on the type of provider, geographic region, size of the provider base, type of services provided, payer mix, and certainly the capabilities to invest in technology will be key to where you might be compared to your peers. It's important that benchmarks be agreed upon and consistently calculated. Internal benchmarking and trending of critical APIs are just as valuable as trending against the so-called national indicators, which are important too, okay? Days of revenue and receivables, also known as AR days. Anybody that's in RevCycle knows we typically live and die by this number. And it's widely used throughout the healthcare profession to measure how fast receivables are collected. The industry standards for AR days are available on HFMA, and you could see the benchmarking data under the MAP information. So for those of you that didn't join us last week, I mentioned that when I started my career at the ripe old age of 12, I assure you, that our mantra when I worked at Sun Kettering was 90 days in 90, All right, that was really before electronic billing and a lot of other processes that have made things very, very efficient. I assure you, if a provider turned around and had 90 days in AR, it's going to be a significant issue. AR aging analysis. Aging reports divide the AR into 30, 60, 90, 120 days, and other categories based on the date of service discharge. The AR may also be aged from bill date. However, this presentation completely masks the impact of any processing delays between the completion of the service and the production of the bill. It is important to age from date of service to understand the impact that timely billing or lack of timely billing has on collection of accounts receivable. Discharge not final billed, or DNFB, an important thing for providers to be managing very, very closely of it. This is the portion of the AR that identifies charges for patients where services are completed, but the healthcare facility has not been able to bill the claim. There are a number of activities that must be completed before bill submission can take place. It includes the completion of all charging, final medical record coding, and could include insurance verification activities if not done at time of service, which it should have been. When I was managing my revenue cycle, we really focused on these days. We had some coding challenges, and they were behind. We knew that. We recognized it. We still reported the number of DNFB, and the director of coding didn't want to report that number anymore because it upset her coders. And I went, well, okay, I understand that. Nobody's taking it to task for it. We all understand that you're understaffed, and we're working to try to get more coders to do something, but not reporting it is just not the right thing to do, right? You have to have visibility as to what's causing impact to your cash, and if it's you, everybody needs to know about it. Another couple of other general KPIs, and these are pretty important in the industry. Because healthcare is not typically a cash upfront business, there is a cost to collect for services rendered. This cost is calculated by dividing the total patient services operating expenses by the gross patient care collections for the same period. Patient financial services expenses must also include admitting registration, which is why it's key to get as much of this money up front so you can decrease your cost to collect. Cash collected is a percentage of net revenue, and that's my real opportunity, right? This key performance indicator is known as the net collection rate. It lets you know how much actual cash you collected as a percentage of what was available to collect. It is the ratio of cash to net revenue. Now, just so you know, there will be months that providers will actually report more than 100% of cash collections over net revenue. And that's certainly due to just variations in the numbers that are reporting. Consistently reporting over 100% of your net revenue. I haven't figured out how providers do that yet. Love somebody to teach me the tick there, but it shouldn't be more than 100% of your collectible revenue. Denials as a percentage of net revenue. Less than 2% of your claims should be denied on the first submission. I argue that you need to try to bring that down even more and go into more denial prevention initiatives, because the cost to try to overturn denials are significant. And then certainly credit balances, right? Most providers are not sitting here trying to figure out how to give refunds back. A lot of times it's not refunds, it's contractual allowances that were inaccurately calculated, but they should be resolved timely and should be benchmarked as less than 1% of the days outstanding in the AR. Too high credit balances are going to negatively, deflate your AR days and make you look like you're better than you are. Okay, some key points that we want to make sure that we focus on: what KPIs do and how to calculate them. How to evaluate the collection efficiency and why cost to collect is very important. and trying to decrease that is important. And then just completely analyzing your AR and staying top on it. As we mentioned when we talk about things like the aging analysis, the older your claim is, the more costly it is going to be for you to try to collect it, and the less chances you're going to collect it. Your percentage of cash has now decreased substantially. So what are KPIs? And Ken, I really feel bad about this polling question. I really enjoyed them last week. Most of the ones that you're going to see there are components of what KPIs are. But number 4 is the correct answer here, which set the standards for AR and provide a method of measuring. So I again encourage you to review the HFMA map keys in the course, which consists of 25 KPIs divided into 5 major groups: patient access, pre-billing, claims, account resolution, and financial management. Okay, so questions. Anthony, were there any questions on the chat that you were unable to answer related to content?
So there was one earlier. Let me go back. I made a little note.
Thank you.
Was during when you were talking about the ABNs and the 3-day time limit, that early section, there was a question that, forgive me, I'm just scrolling through to find it here. So what if those services within the 3 days are for a different type of service? Would this then be an exception?
So you're going to tie yourself back into the diagnosis code that's being used for the actual admission itself. And so if the patient, you know, went to the emergency room for a sprain, right? You know, I sprained my hand, I want to go into the emergency room, I'm going to go do that, right? But now I get admitted for pneumonia. Hope not. But, you know, patient gets admitted for pneumonia, the sprain is unrelated to the pneumonia and therefore would not be tied into the 3-day rule. It has to be any diagnostic services that are, you know, related to the actual admission itself. Okay. Other questions? We're happy to open it up if people want to join us on video now. And feel free to ask questions. Throw them on the chat if you feel more comfortable, or feel free to join us. And so while we wait for that, again, we've got a few minutes to keep staying on. I'm going to ask Anthony to spend a few minutes talking about the upcoming Florida HFMA events, and then we'll backtrack to any questions that are there.
Go ahead, Johnny.
And actually, I'll jump in on a few things. First of all, thank you so much, Christine, for doing this for us and for everybody joining us. I think we had a record number of about 177 people, you know, on today's call with about 222 registered. So, I mean, this is just incredible, and I really hope that everybody enjoys this session. For those people that don't know me, I'm John Levine. I'm the Director of Membership and President-elect of the Florida HFMA chapter. Just really can't thank you enough. One thing that I did want to say is we are videotaping these sessions, as Christine did say. And I know a lot of people are probably like myself that are like, what did she say? Or it's during working hours and we're kind of not focused on the screen as much as we would like, or just want to go back to it. We will have this actually on our Florida HFMA website. That's Florida, I'm sorry, not the website, but the YouTube channel. And you can just go to Florida HFMA on YouTube and you will find it there. Plus we also put the link on the invite. So there's plenty of ways to get it. We will also be sending out a lot of the questions that people have on the invite as we did last time. But a lot of people ask, how do I get involved in HFMA? What is involved in HFMA? And either on a committee or just different ways. We're really excited that we're going to be having this virtual event. Normally we do it during our statewide, one of our statewide conferences. We do sort of like a volunteer engagement, how to get more involved, what to do, where to go. And for those people that want to get involved, we ask that you please join us from 10:30 to 2:30 We're going to be throwing in some CP credits and some education during this session, but from about 11:30 to 1 o'clock, we're actually going to be doing our volunteer engagement, learn more about HFMA, learn how you can get involved. And it's not just joining a committee, and wanting to get to the board level or chair level. We're really just looking for those people to give us content, what they're looking for, what education we can give. We do have advisory roles. Anthony is the director of education for the Southeast region, and he's always looking for good content to have. So we hope that you join us for this call. If you have any questions, please email myself, Christine, Diane, or Anthony. Any questions on this, or I'll turn it over to my good friend Anthony. Thank you.
Thanks, Johnny. If anybody has any questions and wants to jump on, please feel free. While we're waiting on that, just wanted to give you a heads up. John talked about the upcoming volunteer engagement session that we have set up for those looking for ways to get involved. Another one of the big events that we're trying to pull off in this COVID era is some real good virtual networking and tying that into the education that we've already got planned for what would be our one-day regional events throughout the state. On October 30th, we have what we're calling our Halloween Spooktacular. It's a virtual networking event that is, circled around our Name That Tune networking challenge. We're having a DJ and playing almost a game show of naming that tune, and it should be a really fun hour of getting to know some folks and seeing some of the other more networking centric activities that we do here. Along with that, in the morning we have, throughout the day, starting in the morning at 10, we have 3 education sessions with 3 amazing speakers giving timely topics, and you can get up to 3.5 CPEs for that day on top of the hour networking event. So check us out at floridahfma.org/events, register. They're all free. You don't have to be a member. You don't have to be necessarily even a member of Florida's HFMA. We're open door policy here for these events. We're looking forward to having as many people as we can. So I see we've got a couple of
and hopefully, and one thing I do want to add, Anthony, to that is hopefully when we do go back to normal, we're still going to offer some virtual events, but hopefully we can get back to on-site. We can offer, if you're interested in having a one-day event at your organization, please let us know, and also bring in our certification on the road as well. Thank you.
So, I'm sorry, go ahead, Christine.
Are there questions?
Yeah, there's a couple things I want to just get to you quickly here before, if you could touch on them briefly.
Yeah.
So we have a member that's having some trouble getting in touch with HFMA about their e-learning because their course seemed to have expired. Any recommendations on who they can reach out to? They're having a hard time getting in touch with someone.
Yeah, career services at hfma.org. On the 800 number, if you ask for the career services, once you get to them, Shirley Headland, who is the certification guru, I guess, at HFMA National. We had somebody have that happen a couple of weeks ago. They reached out to Shirley and they got it really corrected. So probably what ended up happening is you signed up for the course, you did not complete it in the time that you were given. It is expired, so she has to extend it for you. So you'll have to reach out to career services at hfma.org.
Great, thank you. And then just your personal recommendation as far as strategy, quickly, if you can, on retaining it. Essentially, this is so much content and so much information. And any personal tidbits or recommendation on how to retain all this?
So my recommendation is to take this course and then in the next week, go out into the e-learning and take the 5 sections that we did, right? And then just use that material to reinforce the information that we went over in each section. So you've got to do that homework. I'm going to tell you right now, this course alone, this session alone, probably will not have you pass that assessment.
Coming from a CRCR, yes, you have to study.
Absolutely. A lot of material, but take a chunk at a time, guys, and figure out your learning style. I write things down. I write them down, I recall them that way. I reread them over and over again. So learn your learning style and just to figure it out and do that. Okay. Any other questions, Anthony?
The only last question would be is in reference to the 3-day window we mentioned again in the earlier question, is there anything, any sort of documentation or printout from CMS that would state that language specifically? That
Oh, absolutely. Yeah, if you go out to CMS and you Google the 3-day window or the D or G window, as they call it, then you will find copious materials. Google is your friend when it comes to trying to figure out things in HFMA or anything, and honestly. You know, just if you go out into 3-day window or D or G window, you will find tons of materials, and I'm sure you'll find something from CMS.
So there's really no other questions. I just wanted to give just a personal thing. Within the CRCR materials, there is a printable topic list, almost like a skeleton outline that I used. What I did was I copy and pasted into a Word document, gave myself extra space in between each item, and then used that as how I took notes during the modules and the studying. So,
and you're going to all of these materials will be given to you. So you can actually print those handoffs out if you want, and then maybe write on the materials as you're going through the e-learning session, whatever, you know, but you got to have to study that material. And I would suggest going through all the materials. We're going to do one quick session at the end, right before. We're going to do 9 weeks. 8 weeks will be focused on net new contact. And then the last 9 of the session will actually do some questions throughout the entire units.
And I will say this is our first time that we're doing this, so we're sort of learning as we go. You're going to be getting a survey from us. You should be getting it every week. And if you can complete that survey, let us know how we're doing. Let us know what we can do better. I think there's some things that we've seen. We are going to be having sort of like everybody's learning together on the last session. But if there's things that can help you, let us know, and we're here to help and make sure that you become certified. Just always give us a call, and we'll go from there. Thanks.
Yeah, absolutely. Love radical candor. Please feel free to let us know what we can do better. My first time doing it as well. I want to help you guys. So appreciate it. Feedback you can give us. Better and different.
Yeah, and there was one question about how long to wait for the YouTube. I would say probably it will go up on Tuesday. There's some internal things that we have to do, but definitely wait till like Tuesday, Wednesday, but it will be up. And we'll also put the slides on FloridaHFMA.com, and you can find them there.
Yeah, the first session is already on the YouTube channel itself. I have not watched it. I don't know if I want to.
It was great.
but it is out there available for you guys to review as well. Okay.
Thanks, everyone.
Thank you so much.
Thank you guys. Have a great rest of your day. Bye-bye.